This was a competitive process. We had a number of faculty, fellows, and residents submit abstracts in committee, including Tammy Brady, David Cook, Michael Osto, Bernina Tama, and myself selected the 4 best. And it's a good representation of investigators at different levels. The first speaker is Dr. Scott Blackman, who is a faculty member in the Division of Pediatric Endocrinology. And he's going to speak about genome-wide association, detects genetic modifiers of CFRD, and evidence of pleiotropy with meconium ileus. So Scott, go ahead.
All right, thank you so much for the opportunity to speak and for selecting this project for scientific abstract. It's humbling to be selected among this to this group. This is a presentation that was selected for platform presentation at the 2020 North American CF Conference. I've modified it just a little bit for the audience. And this is presented on behalf of the CF Genome Project, which is a multi-center study funded by the CF Foundation and run by investigators at the 5 universities shown on the screen. Let's see, okay. So first, I'd just like to highlight the main differences between CFRD and type 1 and type 2 diabetes for this audience. So as you know, type 1 is usually seen in younger people and type 2 is usually seen in older people. CF-related diabetes essentially is absent before age 10 with rare exceptions, and then is diagnosed with increasing frequency at increasing age steadily. It occurs mostly in normal or thin people with CF as opposed to type 1 and type 2 diabetes. It's a disease of insufficient insulin production, not a disease of insulin resistance, although there is some residual insulin production, not as extreme as in type 1. Here's an example of C-peptide production in people who don't have CF, in people who do have CF with pancreatic sufficiency or insufficiency, and people who have CFRD on insulin but still have some insulin production, albeit delayed. There is something called islet amyloid, which is found in people with type 2 diabetes, as shown in the left panel, and people with CF-related diabetes, as shown on the right panel. This is either a marker of beta cell destruction or is potentially toxic itself to the beta cell. CFRD is not a disease of autoimmunity, and the complications of diabetes do show up in people with CF, and including typical microvascular complications, possibly macrovascular complications, although it hasn't been found yet. But the main complication of CFRD to people with CF is lung disease. Okay, so CFRD, again, is one of the most important complications of CF occurring with increasing age. CFRD is influenced by genes, including the CFTR gene, and also modifiers, which are genes elsewhere in the genome. Let's see, sorry. So in the people who have residual pancreatic function and exocrine pancreatic sufficiency, the risk of CFRD is reduced by about a factor of 20. We also have previously found in candidate studies that family history of type 2 diabetes increases the risk of CFRD, and at least 16 risk genes for type 2 diabetes are also CF modifiers. We previously constructed a polygenic risk score for type 2 diabetes and found that that was associated with CFRD as well. Our previous study also identified variants at SLC26A9 which is a gene associated with Meconium ileus, as associated with CFRD. Meconium ileus is a form of neonatal intestinal obstruction that affects about 15 to 20% of people with CF. I'm showing two figures from our second CFRD genome-wide association study. 3 loci were identified with genome-wide significance and replicated in an independent sample. SLC26A9, which I mentioned, variants also at TCF7L2, which is a type 2 diabetes risk gene, and at a third locus called PTMA. PTMA encodes prothymosin alpha, which is involved in oxidative stress, inflammation, and other pathways. The polygenic risk score adds up the genetic risk for CFRD across all 18 modifier loci that we identified. So I'm showing here the risk of CFRD to people with CF and exocrine pancreatic insufficiency. The risk of CFRD varies as a function of this risk score. For example, at age 25, only about 15% of the lowest risk group has diabetes compared to about 50% of the highest risk group. The CF Genome Project was further described in 7 other abstracts at that meeting. The work, this is essentially recruited 5,000 people with CF and subject to whole genome sequencing. The work I'm presenting used 8 million variants with at least 1% minor allele frequency. Phenotype information was derived from chart extracted data and from the cystic fibrosis patient registry. There is overlap between the CFGP samples and our prior GWAS studies. The GWAS on the last slide used 5,740 individuals. In the next few slides, we'll show results on the set of 1,681 individuals who were in the CFGP but not in prior studies. Now I'm skipping over some of the data that was originally presented at the meeting for this audience, but I will show you the replication of our 18 SNP polygenic risk score in the independent population. And again, you can see that by about age 30, about 80% of people have CFRD in the highest risk group compared to about 30% in the lowest purple risk group. But what I'd like to focus on for the rest of the talk is the idea of pleiotropy, which means that gene variants affect more than one trait. I already mentioned that CFRD modifier SLC26A9 is also a modifier of Meconium ileus, which is neonatal intestinal obstruction CF. This most recent MI-GWAS identified 5 other suggestive or significant loci: TARS PRSS1, which encodes trypsin, ATP12A, CEBPB, and SLC6A14. So we asked the question, are any of these modifier variants associated with CFRD? So we already knew about SLC26A9, the top row, which is associated with both CFRD and Meconium ileus. And in fact, 2 of the other 5 variants also had study-wide significant association with CFRD. That's PRSS1 and CEBPB. And each one of these is interesting, as I'll describe on the next 2 slides. SLC26A9 encodes a chloride channel which interacts with CFTR, and we have recently published a study demonstrating that A9 and CFTR tend to be co-expressed in pancreatic ductal cells, and that the risk variants for MI and CFRD are associated with reduced expression of SLC26A9 and reduced immunoreactive trypsinogen levels in newborns. This suggests that increasing exocrine pancreatic function may be protective against CFRD. There is a slightly more complicated story for the PRSS1 locus. PRSS1 encodes cationic trypsinogen, which is processed into trypsin and is probably the most important digestive enzyme in the pancreas. The variants at PRSS1 are previously identified to be associated with decreased gene expression and reduced risk of chronic pancreatitis. So, in other words, decreased expression of PRSS1 seems to reduce the risk of CFRD. So this actually suggests there may be a place for an old hypothesis that pancreatic autodigestion may be involved with CFRD. On the other hand, reduced expression of PRSS1 is also associated with increased risk of MI, so it's in the opposite direction. And we and our other colleagues in the International CF Gene Modifier Study have speculated that this could be related to thickening of the meconium with reduced pancreatic function. Sorry about my typo there. There is less known about CEBPB, which is a transcription factor. I'll point out that CEBPB is triply pleiotropic, with the same variants increasing the risk not only of CFRD and MI, but also of type 2 diabetes. It was recently noted that CEBPB can regulate the expression of Claudin-4, which is a tight junction protein. This is interesting because a related gene, Claudin-2, is a risk gene for chronic pancreatitis. So while we don't know the answer yet, one might speculate that CEBPB could affect the expression of Claudin-2. So in summary, the initial CF Genome Project analyses have identified 3 pleiotropic loci which affect the risk of both CFRD and meconium ileus, with a slightly different story for each. The directionality for SLC26A9 suggests that worsening pancreatic disease increases the risk for CFRD and MI. The PRSS1 variants act in opposite directions and lend some support to one of the oldest hypotheses in the CFRD field relating protease activity to diabetes risk. The third locus is also a type 2 diabetes risk locus, with work yet to be done to elucidate its mechanism of action. And I would again like to highlight the CFRD polygenic risk score, which effectively stratified CFRD risk in this study. I'd like to thank the CF Foundation for the funding for this consortium, which has had quite a few interesting findings in only 11 months since getting the sequence data. I'd like to thank all of the co-investigators in the CFGP for helping create a fantastic initial set of studies. And I'd like to thank the patient registry for helping fill out our phenotype data. And I'd like to thank all of you for your attention. Thank you.
Thank you very much. In the interest of time, if you have a question, write your name in the chat box and we will get to you at the end. All right, so our second speaker is Morgan Drucker, who's a member of the residency program, and her talk is improving antibiotic discharge stewardship within the pediatric emergency department.
Hi, good afternoon, everyone, and thank you for giving us the opportunity to present here. I will also be co-presenting with one of my co-residents who worked on this project, Dr. Emily Crosby. So this work was presented recently at the Pediatric Academic Societies and was started as a quality improvement project with members of the Pediatric Emergency Department and Pediatric Infectious Disease. So we know that excessive antibiotic use is associated with negative consequences, and these include things ranging from things like increasing antimicrobial resistance to increased C. diff infections and acute kidney injuries. And knowing all this information, the federal government came up with a 2015 National Action Plan for combating antibiotic-resistant bacteria, which aimed to reduce inappropriate antibiotic prescribing in emergency departments and other ambulatory settings by 50% over a 5-year period. However, there are a few studies that evaluate antibiotic prescribing practices within pediatric emergency departments, and we know that this is a unique setting, and there are variables that are unique to emergency department settings that can make value care more challenging, and these things include things like an increased number of providers with variable levels of training and variable levels of experience within pediatrics itself, a high volume and rapid patient turnover. We do have evidence-based guidelines here at Johns Hopkins that recommend 5 days of therapy for uncomplicated community-acquired pneumonia or CAP and skin and soft tissue infections. And these are based on evidence that shows that the 5 days of therapy is the best treatment for these infections. So the goal of this study was to reduce the proportion of children discharged from our pediatric emergency department with a diagnosis of community-acquired pneumonia or skin and soft tissue infection who receive antibiotic prescriptions for more than 5 days of therapy by 50% to meet with that national action plan goal. The way we went about doing this study, so we obtained baseline data to begin with by reviewing medical records of children discharged from the pediatric emergency department from March through November of 2019 who had a diagnosis of community-acquired pneumonia or skin and soft tissue infections. And the data that we gathered here included things like patient age, their gender, what their discharge diagnosis was, what antibiotic was selected, and the duration of therapy that was selected. Our intervention period then began in March of 2020, and we began distributing educational materials that recommended 5 days of antibiotics for these infections, which included uncomplicated community-acquired pneumonia and skin and soft tissue infections. And these educational materials were in the form of emails that were sent to providers who worked in the pediatric emergency department, as well as flyers. And we also have cards that were placed on computer stations that reminded people about the 5-day prescribing, where in the pediatric infectious disease blue book they could find these recommendations. And then while we were doing this, we also put in a request to the Epic EMR to change the automatic duration that comes up when you go to prescribe discharge antibiotics, which currently was coming up as 10 days. And so with these reminder cards, we also made a reminder to let people know too that they would have to manually change that automatic prescription guidance that comes up in the medical record. And then we collected data ongoing monthly with those same parameters that we were looking at. And then at 3-month intervals, providers whose prescribing practices did not adhere to these guidelines received targeted interventions. And this is an ongoing study, and we are still in the process of gathering cycle data and undergoing these 3-month interval interventions.
Great. So moving on to our results, we included in our analysis only the prescriptions for patients who had uncomplicated CAP and skin and soft tissue infections, and for whom a 5-day antibiotic course would therefore have been appropriate. For our pre-intervention period, we ended up with a total of 326 antibiotic courses prescribed from March 2019 to November 2019, of which 64 were for CAP and 262 were for skin and soft tissue infections. In our intervention period, so this is when we started the clock in March of 2020 with the reminder cards and the education to newcomers to the ED, we ended up with a total of 155 antibiotic courses from March to November of 2020, of which 23 were for CAP and 132 were for skin and soft tissue infections. And this much lower number of prescriptions in 2020 reflects the lower overall PEDS-ED volume in 2020 due to the COVID-19 pandemic. So in this first figure, we have our results for community-acquired pneumonia prescriptions, and we have them grouped by dates, 2019 being our pre-intervention group, 2020 being our post-intervention group. And then on the y-axis, we have our duration days of treatment. And as you can see, most fall into the 5, 7, and 10-day durations. What we found was a reduction in the mean antibiotic course for CAP from 7.4 to 6.4 days pre and post intervention, but this was not statistically significant with a p-value of 0.143. Next slide. This next figure shows our results for skin and soft tissue infections. So again, we have our results grouped by date, so 2019 being pre-intervention, 2020 being post-intervention. And then our duration, again, mostly falling into the 5, 7, or 10-day durations. What we found here is that the mean duration of discharge antibiotic courses was reduced from 7.1 to 6.7 days in the post-intervention group, and this was statistically significant with a p of less than 0.001. Next slide. So those first two figures were showing the average antibiotic duration. This final figure shows the percentage of antibiotic courses each month that was in excess of the appropriate duration of 5 days. This combines data for both CAP and skin and soft tissue infections. Again, we are grouped by date, so month and year. And then on the y-axis, we have the percentage of prescriptions that were too long. And so you can see before the intervention, we were at almost 70% for prescriptions from the PD. And then after the intervention, we got to just below 50%. Next slide. So to conclude, we found that prescriber education alone was able to reduce the proportion of children with a discharge diagnosis of CAP or skin and soft tissue infections who received antibiotic prescriptions in excess of 5 days. This was a very simple intervention. It was not time or labor intensive, and it's going to be sustainable to continue for incoming trainees in the PEDS-ED, which is important given the constantly rotating workforce there with various levels of pediatric experience. and emergency medicine training. Of course, our data from 2020 was limited by the decrease in the PZD patient volumes due to COVID-19, but we do anticipate higher numbers this year for further data collection. And as Morgan stated, this is from our first PDSA cycle. We still have a lot of work to do to meet the National Action Plan's goal of reducing excess antibiotic prescriptions by 50%, as nearly half of children with these diagnoses are still leaving our PZD with excess antibiotics. Our next intervention that we are hoping more substantially brings down this excess prescribing is the removal of that 10-day default duration. After being about a year in the making, this change was recently implemented, which we hope will encourage providers to be more thoughtful about antibiotic durations in the future. And with that, we're happy to take any questions in the chat.
That was an excellent presentation by both of you. And we will look for the chat questions at the end because we're sticking to the time fairly well. All right. So our next speaker is Jacqueline Manfredo from the Pediatric Endocrinology Division. And she will present on body composition and diabetes risk in South Asian youth.
Hi, thanks so much for inviting me to speak here today. It's a pleasure to get to talk to you guys about some of the research that I've been involved in. So as Dr. Murphy was saying, that I'll be talking about body composition and diabetes risk in the South Asians compared to white and African American peers. And I'd like to thank all of my co-authors for their contributions and support. So just a little bit of background. South Asians adults have a greater risk of type 2 diabetes and cardiovascular disease at lower BMIs compared to other ancestry groups. And we don't really know the reason behind this, but it's thought to be related to increased visceral or central adiposity. Studies have shown that compared to other ethnic groups, South Asians have higher percent body fat, visceral adiposity, and abdominal adiposity for a given BMI. South Asian adults have evidence of increased insulin resistance and dyslipidemia, as well as decreased insulin-mediated glucose removal and beta cell function. So the objective of this ongoing study is to examine the ancestry-related differences in cardiometabolic risk factors in South Asian, white, and African American adolescents. So this is an ongoing study. The South Asian groups are being recruited first because the white and African American control groups will be matched based on age, sex, and BMI. But since we haven't recruited any of the white and African Americans at this time, this analysis was done using white and African Americans as a convenient sample from another study that was previously done. The inclusion criteria were adolescents ages 12 to 21 years that had a BMI greater than or equal to the 80th percentile if they were less than 18, or greater than or equal to 23 if they were 18 or older. So I know that we're used to thinking of overweight as greater than or equal to the 85th percentile, or BMI greater than or equal to 25, but in South Asians, it's actually, if your BMI is above 23, you are actually considered overweight. And so that is why a different percentile was chosen, or these different parameters were chosen. The exclusion criteria were a known diagnosis of diabetes, major organ illness, or if they were on medications that are known to affect insulin sensitivity. As part of the study, participants had fasting metabolic labs, including glucose, insulin, and lipids. HOMA-IR, which is a measure of insulin sensitivity, was calculated using fasting insulin and glucose. And anthropometric measurements were obtained, including waist circumference, waist to hip, and waist to height ratios. For the analysis, we did a descriptive analysis using ANOVA or Kruskal-Wallis if the distribution varied from normality. And we did linear regression to adjust for potential co-founding variables, including age, sex, pubertal staging, and BMI-Z, and just test for the interaction by group. So this is a busy table. I know there's a lot of information, but this is the demographic table. And so because the white and African Americans were a convenient sample, you will note that they African Americans are heavier, so they have a higher BMI than the white and South Asian groups, and that the South Asians are older than the white and African American groups. They're all similar in terms of the fasting lipids and fasting glucose. However, the important thing to note is that there's a significant difference in fasting insulin and HOMA-IR between groups. There's also a significant difference in the waist to height ratio and waist circumference between the groups. And this is most likely related to the African Americans having a higher BMI. So this slide shows the box plots for the waist to height and waist to hip ratios. And you'll just note that the whites are on the left, African Americans are in the middle, and South Asians are on the right. African Americans have a higher waist to height ratio because they have a higher BMIs, but they actually all have similar waist to hip ratios. This table is actually showing the regression results between HOMA-IR and the anthropometric measurements. After adjusting for age, sex, and pubertal stage, the log of HOMA-IR was positively associated with waist circumference, waist to hip ratio, and waist to height ratio in the white and South Asian cohorts. And you'll see that here. However, when you do an additional adjustment for BMI-Z, you will notice that it's no longer significant in the white group, but it remains significant in the South Asian group for waist circumference and waist to hip ratio, and borderline for waist to height ratio. This is suggestive that there's a role of central adiposity not accounted for that BMI difference. In this next slide, is a graph of the linear regression of the log of insulin versus BMI-Z. The whites are in blue, the African Americans are in green, and the South Asians are in red, and with the dots being the original data points. The lines are the regression results when you adjust for sex, age, and pubertal stage. So you will note that because the African Americans are heavier, there's not a lot of overlap between the green X's and the red triangles, and so it's difficult to make a comparison between these two groups. However, when you compare the South Asians in the red to the whites in the blue, you'll note that for a given BMI-Z, the South Asians have a higher insulin level, and this was found to be significant. Similarly, when you're looking at the log of HOMA-IR versus BMI-Z, you will again see that the South Asians have a higher HOMA-IR for a given BMI compared to the whites, and this again was significant. So in conclusion, compared to white groups, the South Asians had a higher fasting insulin, HOMA-IR, for a given BMI-Z, after adjusting for age, sex, and pubertal stage. The South Asian, white, and African American youth had a higher HOMA-IR with increasing waist circumference, but after adjusting for BMI-Z score, this persisted only in South Asians. And when the South Asians and whites had a higher HOMA-IR with increasing waist to hip ratio, but after adjusting for BMI-Z, only persisted in South Asians, which suggests a pathologic role for central adiposity. And so increased insulin resistance may contribute to the increased diabetes risk we see in South Asians. I'd like to thank all the study participants and families, as well as the grant support that has gone to support this research. And thank you all for your time.
That was terrific, Jackie. And we looks like we have a few questions in chat, but we will move on to our final speaker, who's Brandon Smith, talking about emergency department and inpatient utilization after school-based health clinic.
All right,
I should
great.
say center, not clinic. And the rest of the title is up there.
Yeah, it's a long one. Thanks, Dr. Murphy. And yes, thanks to the department and to everyone on the committee for the opportunity to present our work today. I'm going to be sharing this our project with you that I presented at both the APA Academic Pediatric Association Region 4 conference, as well as Pediatric Academic Societies meeting just a couple of weeks ago. And first, funding support for this work was provided for by the Robert Wood Johnson Foundation Clinical Scholars Program and a gift from the Norman and Ruth Rales Foundation. And today I will walk with you through the background, methods, preliminary results, and the discussion section for this project, and end with where we will go from here. So as background, 1 in 5 children are diagnosed with a mental health or behavioral health disorder during their childhood. And this includes some of the disorders that are listed in the yellow box to the right, such as ADHD and anxiety. And unfortunately, despite the high prevalence, up to 50% of kids are not getting adequate mental health care for these diagnoses. And this is even worse for Black and Hispanic children, who have half the rate of outpatient mental health visits compared to their white peers. At the same time, children with mental and behavioral health disorders are increasingly using the emergency department and urgent care services. And I imagine that many of you in the audience today have witnessed this trend firsthand in our own emergency room. We know that the ED is quickly becoming a first stop for children with mental health crises. Combined with low numbers of inpatient beds and other factors at play, this frequently results in prolonged length of stays in emergency departments that are often not equipped to care for these children and for their needs. And again, there are differences in use for Black and Hispanic children. From 2011 to 2015, national trends in ED use for mental health complaints were 50% higher in African American and 90% higher in Hispanic children compared to their white peers. With those numbers in mind, I want to turn to another mechanism of care delivery for kids that could make a difference here, and that being school-based health centers, which provide both preventative care and urgent care services to children in their schools. School-based health centers have demonstrated benefit for both health and education outcomes and promote equitable delivery of care to underserved populations and communities. And school-based health centers are also associated with reduced acute healthcare utilization, both emergency room visits and hospitalizations. However, most of this research that's been published has been performed at a school district level, comparing school populations with and without health centers. It's also heavily relied on survey data of students or parents and mostly focused on adolescents. And with that knowledge in mind, we identified a gap in the literature, which is that less is known about the experience of children with mental and behavioral health disorders after they have access to a school-based health center. And so therefore, our objective in this study was to compare acute healthcare utilization rates before and after school-based health center enrollment for kids with mental and behavioral health disorders. And we do that by looking at 1, ED visits and 2, inpatient admissions. And the work presented today is from the Ruth and Norman Rales Center, a comprehensive school-based health center that opened in 2015 and is supported by faculty at the Johns Hopkins Children's Center. Grades K through 8, and more than 70% of students in the school are enrolled at any given time. The center is staffed by full-time clinicians who can see students at any time during school hours, and those students could be seen for acute needs, chronic disease visits, or well child care in concert with their primary care pediatricians. And students can also be treated for certain mental and behavioral health disorders, such as ADHD management or depression, and then referred to community or school-based mental health providers as needed. So for this project, we identified school-based health center enrolled students with Medicaid insurance during 4 academic years, from 2015 to 2019, and then identified those in that population we identified those in that population who had a mental or behavioral health disorder through their electronic health records. And for each student, we defined an intervention period, shown here in the green, that consisted of their enrollment period in the clinic. And then we defined a baseline period of up to 3 years prior to that, as shown here in the blue in the diagram. And we used an interrupted time series design with segmented regression to compare the baseline and enrollment time periods. And we used a mixed effects Poisson regression model, which accounted for the longitudinal nature of our data over time for each student. Our primary outcome measures were quarterly rates for both ED and inpatient admissions, and each measure was calculated quarterly to account for seasonality. ED visits were identified by ED-specific revenue codes, and any ED visit that resulted in an admission was excluded from the count of ED visits. Our predictor in the analysis was the student's enrollment time period in the health center. And we included a lag time of 6 months at the start of each student's enrollment period, which is consistent with prior literature in the area. So from 2015 to 2019, we identified 1,724 students who were enrolled in the school-based health center. And of those, 1,035 were determined to have Medicaid insurance through school-based health center records at any time point during those 4 years. And of those students, we identified 138 as having a mental or behavioral health disorder, which made up our final study population. And we then obtained Medicaid claims data for each student during their baseline and enrollment periods. And so of those 138 identified students with a mental or behavioral health disorder, the most common diagnosis was ADHD, as seen here in blue in the pie chart at 58%. Mean age was 9.2 years, 34% were female, 90% were identified as non-Hispanic Black. Mean enrollment time in the school-based health center was 31 months over a maximum possible of 48 months during the study period, and 85% of students had at least one visit to the health center. So first, in an exploratory analysis, we wanted to look at the general trends over the available time period in the study for both ED visits and inpatient admissions. And so here in the 2 graphs, the y-axis is a measure of mean encounters per quarter, and on the x-axis are the calendar years from 2012 to 2019. And as you can see in the purple line, I've indicated where the school-based health center opened in the 3rd quarter of 2015. And overall, as you can see, there was already a downward trend for both ED visits and inpatient admissions prior to the school-based health center opening. And then this trend continued after 2015, although we did observe a drop-off in the utilization rates after opening. However, as I mentioned, these trends were just exploratory and simply show the utilization outcomes over the time period in our data set. And they don't really account for when students actually enrolled in the health center itself, which could have been at any time point after 2015 or to the right of that purple bar. So to look at the individual student level, I'll turn next to our main analysis. And here we analyzed the mean quarterly visit rates during the enrollment versus baseline periods at a student level. And drawing your attention to the 2nd row here in the table, you can see that our results show that the rate of ED visits was 0.66 times lower for students during their enrollment period as compared to the baseline, which was statistically significant. And then for inpatient admissions, the rate was 0.73 times the baseline, but not statistically significant. So therefore, drawing your attention to the large yellow box, our takeaway in this slide is that in our preliminary unadjusted analysis, students with mental and behavioral health disorders had statistically significant lower rates of emergency room visits after enrolling in a school-based health center. In conclusion, our preliminary results are consistent with prior literature showing that children's utilization patterns change following enrollment in a school-based health center. And it suggests that we may be able to reduce the need for urgent and emergency care for students with these disorders by delivering care in an accessible, familiar setting like their school, which could have an even greater impact for students in underserved communities where many school-based health centers are located. However, more questions need to be answered in additional analyses. For example, is this reduction in ED visits related to physical versus mental health encounters? And are there differences by certain variables like age, diagnosis, and school-based health center use? Limitations to this study include its single site design and potential for selection bias, as well as the diagnoses that were based on ICD coding alone. So as I mentioned, our next steps include a few additional analyses to further characterize students' overall utilization patterns, comorbidities, and reasons for visits. We also plan to compare to a propensity score matched control population, and we'll eventually look at associated Medicaid expenditures as well in this population. So with that, I want to thank the full team at the Rail Center who have helped in many ways for this project, and to our funders, and again to the department for this opportunity to share our work today. Thank you.
That was great, Brandon. Let me see what's in the chat box. All right. So Dr. Maggie said, great presentations all around. Thank you, Sheila. And Marquita was also praising the presentation of Morgan and Emily, and as was renal GI. So they're all positive comments. Does anyone else have any questions? If so, unmute yourself and just ask the question.
I had a question for Morgan and Emily. If they would just talk a little bit about what they think were some of the main drivers for not making the reductions that they had hoped to see, that 50% reduction that they hoped to see.
Sure. I think that some of the limiting factors are the education that we provided was at the beginning of the rotation. So every time somebody new comes into the PZD, they get an orientation email. And that is where we included the blurb about, just so you know, the antibiotic recommendations have changed in the last few years, and we are recommending 5 days. This is where you can find it in the Blue Book. And I think probably some people saw that and maybe didn't remember it when the time came. That's where the reminder cards come into play, but I do think that sometimes we get a little bit of reminder card fatigue, knowing that things kind of get tacked up in the emergency room all over the place. And then the last thing is that I think the Epic button is a big deterrent, because when you pop up any antibiotic prescription that you're discharging someone home with, and it says that the duration, like the button to click, is 10 days, you know, that's kind of the reflex that I think, unfortunately, a lot of people end up doing. And so that's why we're hoping that removing that will encourage people to adhere to the other recommendations more frequently.
I think another thing.
I had a question also for Emily and Morgan related to that. When you take out the Epic default, is it going to default to 5 days, or is it just not going to default to anything?
At the moment, it's just not defaulting to anything. And so that was this, the change has come probably, I think, just this last week. And so it defaults to nothing now. And so hopefully the imperative will now have people to kind of look at those reminder cards and look into the Blue Book more, since there is no automatic duration set.
Yeah, you'd probably have even higher success if it defaulted to 5, but then that might have implications for other treatment indications, which maybe you don't want.
Exactly. Yeah.
And for Brandon, a question, were you going to look at, I understand you're going to look at kind of whether the visits were specifically for mental health versus general health, and I think that's a great model to look in the school-based health system. I was just wondering if you were able to parse that out at all in terms of types of mental health issues raised versus not, and also what types of interactions are happening at the school level when they do go to see the provider. Do you have access to that?
Yeah, thank you for that. I think that's a part of our next big phase of this, and I think it's going to be important for us to understand what you're describing, which is what is that use like in the school-based health center and how that drives the outcomes that we saw. So we can and are going back to look at, so what, I guess I'll take a step back. If a child comes to the health center for a complaint like this, they could be seen by a clinician, but they also could have nursing visits for any variety of things. So we're going back to see if dividing out visits in that way in the clinic, and then maybe able to also look down to see, based on the numbers, what those visits were actually for with a clinician, for example. Also, we should be able to look at rates of referrals for therapy, or possibly even looking at those who go to psychiatry or have those claims data also, because we have full Medicaid claims data for all the students.
Thanks.
Mm-hmm.
Any other questions? If not, I've got one. All right, let me ask. I got the impression that you were focused on Meconium-Ileus and genetic associations, but other groups are looking at other features of CF. Is that correct?
So within our consortium,
Yeah.
the people at Hopkins are focused on pretty much on many traits outside the lung. So diabetes and Meconium-Ileus, and also nutritional status being the main focus. There's other groups that are focusing on lung disease, infection, liver disease, but people from all groups are on all phenotypes. It's just where some groups take the lead. So it's a really it's a diverse group of experts, and it's really one of the areas that's been able to proceed through the pandemic as we all got better at doing virtual conference calls and stuff like that.
Mm-hmm. That is really wonderful and should be applied to other genetic disorders as well.
It does look like there's a couple of other questions in the chat box now. It looks like the first one is for Dr. Blackman about any of these genes affecting other pancreatic diseases, for example, cancer and pancreatitis are the ones they mentioned.
Okay, yeah. So the CFRD or Meconium-Ileus modifiers can sort of be put into different buckets based on what we know about them. So some of these risk genes we know very little. But for example, there's a group of CF-related diabetes modifiers that are type 2 diabetes modifiers as well. There's also some genetic overlap with type 1 diabetes, just a little bit. Let's see, the PRSS1 gene, which affects both the risk of diabetes and Meconium-Ileus, that's probably the best example that actually also increases the risk of pancreatitis to at least an alcoholic pancreatitis study group. I don't have anything that I can say specifically about cancer, but yeah. And it looks like, thanks, Dr. Bartlett. It looks like Dr. Nogi also asked about knockouts of any of these phenotypes. So, you know, the SLC26A9 gene, when it's knocked out, it affects actually gastric acid secretion. I think that's probably all I can really say right now about these as far as knockouts.
Leave it to Larry to ask the question about genetics like that.
Great. It also looks like there's one question for Brandon here. What is the comparison with outcomes in students who are in pediatric practices with strong behavioral health support?
Yeah, thank you for that question. I think it's an important point to make also about school-based health centers, and that they are not designed to replace the medical home, but sort of act as an extension and work with the child's existing medical home if they have one. And so we wouldn't be able to answer that specific question exactly in that way, but we are trying to look at when a child was diagnosed with this mental or behavioral health disorder. Was it already at the time of enrollment, or was it after the time of their enrollment in the health center? And I think that might help to answer this in a way about what services they're receiving in the health center that are new, and then have implications for those outcomes.
Dr. Murphy, you're still, you're muted.
Any other questions? Larry, do you want to ask a loss of function question?
He answered it.
Okay.
I just wanted
right.
to also say that I thought it was really nice, the biological plausibility, Scott,
Mm-hmm.
in opposite directions. You know, it's nice when things sort of hang together.
Well, and I think this is a good example of how, identifying modifier genes can actually point you to mechanism. So, we really have very little about the mechanism of meconium ileus, and we have some good ideas about CF-related diabetes, but still not a lot of answers. And I think this is a good example of how you can learn something even if, from these genetic studies.
Yeah, and we see a lot of kids who don't have meconium ileus but have meconium plugs. And, we always sort of evaluate them. They don't generally turn positive for CF, but you wonder about some of these other genes.
Mm-hmm. Yeah, that's a good point.
All right. Well, that was an excellent group of presentations, and I like the breadth of the science, clinical and basic. This was really one of the best of these sessions we've had. So thank you all for your contributions. Thanks to the people who submitted other abstracts, which were very good, and was a tough choice for the top 4.